Okay. Hi, everyone. I will give it a moment for people to start entering in, and then we'll get started here. Okay. So thank you, everyone, for attending. Welcome to Best Clinical Management of TGCT. During this webinar, all patients will have their mics and videos muted. There's a question and answer session at the end, but feel free to add questions to the Q&A button down at the bottom, and the expert presenters and I will direct those questions and have them answered. Please remember that the information provided in this webinar is not intended to substitute for your physician's guidance and care. And my name is Sydney Stern. I'm the Director of TGCT Programs at TGCT Support, and I'll be your moderator. We would like to thank the doctors, Dr. Silvia Stacchiotti and Dr. Sebastian Bauer, and patients for spending their time. So first, to introduce Dr. Stacchiotti. She is a medical oncologist and works in the adult myxomal and rare tumor medical treatment unit at in the cancer medicine department. And I'm going to butcher that name of your institution, so please feel free to correct me. But she works for IRCCS in Milan, Italy. And her clinical and research activities focus on adult soft tissue and bone sarcomas, including TGCT. She is involved in all institutional research activities on sarcoma, and she's a member of the Italian Sarcoma Group, as well as many and various accolades to go with it, as well as ESMO and ASCO groups in the Connective Tissue Oncology Society. And we are so lucky to have her here. And she's also listed as the European Medical Agency External Expert. And Dr. Bauer, just as nicely decorated, he graduated from University of Würzburg Medical School in Germany and received his medical oncology training in West German's Cancer Center in Essen, Germany. He also completed postdoc fellowship at Jonathan Fletcher's research lab, which is a really big deal, if anyone knows Brigham Women's Hospital, and now works as a medical oncologist in the sarcoma program and scientist at West German Cancer Center in Essen. And his research focuses on various sarcomas as well as TGCT for finding new treatments and advancing our understanding of the disease. And I will turn it over to Silvia to share her slides.
Okay. Can you see?
Yes, you are all good to go.
Okay. So thank you, everyone. I think that I and Dr. Bauer, Sebastian, really want to thank all those who are participating into this webinar. And a particular thank goes to Sydney and to the TGCT support group for organizing this meeting and for helping us a lot in spreading the consensus paper all around the world. Then I think we also need to thank a lot the SPAGN, SPAGN and TGCT support group were those who promoted the consensus paper and invited me and Sebastian to join and to work on this. So all of these would have not been done without you. Then, of course, I need to thank a lot Sebastian Bauer and also Giacomo Balli, another Italian medical oncologist. They were, you know, those who basically work with us in drafting and organizing all the meeting. And Sebastian also provided some very good wine to support the effort. And I want to finish inviting all our worldwide colleagues who joined virtually and also in person during our meeting. And I think that from here you can understand that we also spend some time together enjoying the local food. And this was very much instrumental to having a better output from our work. So the position paper was published in 2022, and was very quickly translated thanks to the support of the TGCT group in a live version for patients, an English version that is now going to be translated into many other languages to be of help for patients living all around the world. I think it's important trying to understand why we all together decided to work on such a document. This, of course, was to try to define in the lack of guidelines and considering that the disease is not mentioned in the sarcoma guidelines that are available in the US and in Europe in details, to try to define which is the best, currently to be defined, the best treatment approach to the disease. And this was aimed to, of course, try to optimize patient care and harmonize how TGCT patients are treated for this disease all around the world, but also was an opportunity for us to highlight which are the major needs and the open question on which we need to focus for the future years, and to take a position as a community, which is very important if we want to try to move forward all the criticism that we are facing when we treat TGCT patients. On the other side, for us as a community of experts and patients, it's very important to have a document that align all the group and can be used in our discussion and interaction with pharmaceutical companies and even more with agencies and regulators. It is, I think, very important to clarify that this was an independent initiative. No pharmaceutical company were involved or supported this effort. This had to be a completely independent initiative. And the main meeting was organized in 2022 on the 21st of June in Frankfurt, thanks to Dr. Bauer. And was an hybrid workshop. We were just after the COVID pandemic, and we thought that we wanted to have the majority of the experts on board, even though traveling could have been a bit complex. And indeed, we had people joining from the majority of worldwide regions, so from Europe, North America, Canada and US, Asia and Australia. And in terms of specialties which were involved in this discussion, in these documents, we had all the disciplines that are usually engage in treating and in improving the knowledge of TGCT patient and the disease. So basic scientists, epidemiologists, pathologists, radiologists, surgical oncologists, radiation oncologists, medical oncologists, and also palliative care physician and physiotherapist. And of course, we had a patient representative represented by SPAN and the TGCT support group, among which Sydney, who was really very much instrumental in improving discussion and the document. So here you can see some pictures of when we meet, both in person and all the virtual meeting we had ahead of the main discussion. In terms of methodologies, we had first to identify the expert to be involved into the project and also to define a subgroup to work on the single topics that are included in the document, surgery, radiation therapy, medical treatment, and so forth. Then we perform the most comprehensive possible literature review. Then we met several times virtually, and we drafted a first pre-meeting document in which all the most critical and controversial topics were underlined. And everything, but especially the controversials, were discussed during the hybrid meeting that we had in Frankfurt. And then afterwards, we put together all the comments and we drafted the final version of the document, including also the level of evidence and the grade of recommendation of the main statements that you can now find in the position paper. And then we submitted the paper in September 2022. So basically it took 1 year from the initial idea to the submission of the paper to work all together. This is the scale of the level of evidence. This is a scale that is adapted from the Infectious Disease Society of America, and this is used also for the ESMO guidelines. Basically, this case helps us in clarifying which is the evidence, which is the literature, which are the data available to support each statement that you can find in the document. While here there is another scale that is a way to clarify which is the level of recommendation that is provided for each statement. Then, as a group, we decided to publish this paper as an open access to make this available to everyone. And this again was thanks to the economic support by patient advocates. And as we said, we had the translation, the live version for patients. In terms of contents, you can see here that basically all the treatment phases that are faced by a TGCT patient were addressed, starting from the diagnosis, imaging, pathologic diagnosis, all the principle of treatment, and then also follow-up and future perspective. In addition, only in the live version for patient, there is a flow chart which try to summarize and simplify the treatment strategy that has to be considered in case a nodular or a diffuse type TGCT tumor is diagnosed. Our future plans are, of course, to try to spread the document the most we can. And as said, we really believe that the live version can be very instrumental. We mean to use this document for our meeting with regulatory bodies when new drugs will have to be discussed together, including repurposing of all drugs. And we, of course, mean to go on working together as an expert and patient community to improve this document that is intended to be an evolving document and also a document that is not yet addressing all the questions. So many questions still remain to be addressed for the future. We are thinking about a prospective registry, and in general, we think that TGCT represent a case of a case model, if I can say so, and can be a very good example of how we can improve the treatment of rare tumors, not only TGCT. So, this said, I don't know if there are any questions on this part. Otherwise, I give back the floor to Sydney for entering a bit more in detail into the contents and answering some questions.
Yeah, so we'll start to go through kind of briefly what those recommendations look like. And I see someone asked a question, and when we get to that section, we'll add that question to it. So feel free to just keep the questions coming. And so at first, we discussed the difference between nodular, or previously known as localized disease, versus diffuse. Do you guys want to talk about why that name changed? And is there any biological difference between localized and diffuse disease, and maybe how that's diagnosed? And Dr. Bauer, do you want to start? And then Dr. Stacchiotti?
Yeah, you're touching a point. So this starts already with a pretty controversial discussion that we had. So we had I mean, one would imagine you have experts from all over the world sitting there, and as experts, everyone agrees with each other. But in this case, nobody agreed. So we had the camp of pathologists who thought, well, we decide what's nodular and what's diffuse. And many of us clinicians felt that this does not reflect what in our clinical reality is important, because typically a biopsy couldn't tell you whether the growth is diffuse. And most of us clinicians felt that there is too little evidence to say that there is a true biological difference that can be seen under the microscope that would tell you that there is diffuse or nodular. It's more about the growth. And we believe the growth pattern is something that, unless your whole joint is removed, is something that you typically can only see clinically with an imaging study, and usually not with pathologists. And the pathologists were not angry, but we more or less agreed to disagree a little bit. But I think for you as patients who are listening here, I think the prime aspect of this is that we have helped to clarify with those definition what really matters clinically. And I think before the first active treatment has been made, it is important that there has been a firm assessment of your leading clinician to say, well, this is nodular or this is diffuse, because it has implications in terms of prognosis, in terms of aggressiveness of approach. And again, this is a disease where you have a huge risk of overtreatment and also undertreatment. And I think that is a topic that is particularly grave in this disease. And this is something we realized also in this great interaction of this consensus meeting that we had. And actually, thanks to you, Sydney, I mean, you again and again reinforced the challenges that patients have from opposing statements from their physicians, where you really asked, well, we need clarification and make a decision so that we can rely on this. And that really helped to shape this recommendation.
Thank you. Dr. Stacchiotti, do you want to talk about maybe why you went with the word nodular instead of localized?
Yeah, the reason for deciding in favor of this definition was that basically all TGCT are localized.
To the joint, right? To the joint area.
Yes, localized means not spread outside the joint of origin on one side, and also that according to the radiological features, is easier to distinguish when a TGCT is a nodular type, as the features are all of a nodular lesion. So we all felt that using nodular, which means a different prognosis and a different resectability versus diffuse, was more clear than localized. On the other side, to go to your second question, we all agree that we are talking of a spectrum of the same disease. So in terms of molecular alteration, we are not facing two different contexts, but the same tumor type.
So last kind of question on this definition is, a lot of patients when they're diagnosed worry about whether if they leave their nodular tumor, if it will become or evolve to a diffuse type tumor. Do you want to talk about whether that changes or whether it just stays nicely encapsulated? And Dr. Bauer, you can go first if you'd like.
It's a very good question, and I think there is not a lot of data on this, but I think it is not a process that happens like it's typically not a disease that changes dramatically quick. So if you have a nodular disease and you are asymptomatic, I think it's safe to do a follow-up and not be afraid of this exploding into a diffuse lesion. I think that is a statement that I would give to patients. I have to say that I'm a medical oncologist, so I don't actually see that many patients who have nodular disease, because typically I see the patients who have broadly diffuse and symptomatic disease. That's why they come to me. But we don't have, I don't think we have evidence of like there is a 1% risk of a nodular going into diffuse. I think once you have the diagnosis, I think this applies to you in the first place. I don't think that one should worry a lot that this changes quickly into a diffuse TGCT. Silvia, but I don't know what you would, maybe you can comment on that as well.
So as you said, I think that our knowledge of the disease is not yet full. So probably in terms of biology, not that much in terms of molecular features, but morphology, there is still a lot that we need to learn. What is clear is that if a nodular lesion is completely resected, the risk of a relapse is limited, but not, the risk is higher if there is a kind of morcellation of the nodular lesion. And so in that case, you can have a multifocal relapse.
And that means like to break it open, right? You're breaking it open.
Yes.
Yeah.
Yes. And I tend to think that probably there is a kind of evolution in the sense, and I tend to think so because usually small joints like the fingers are affected by the nodular type, while the knee is affected by the diffuse type. I think this is probably due to the fact that in the fingers, you may understand that there is something wrong when the lesion is small, while probably in the knee, it takes longer, and also symptoms can be misinterpreted with other things. So I think that we still have a lot to understand, but what is very crucial for the nodular type is to be treated with the correct surgical approach in a center of expertise.
This goes to like the next part really nicely, which is imaging and some of the recommendations. So if you want to go to the next slide. We have some of the recommendations of imaging, and some of those recommendations suggest to use maybe contrast dye when available, so that the contrast dye can be subtracted if necessary, and that MRI is specifically the imaging technique of choice to detect both the disease and recurrence of it. Dr. Stacchiotti, do you want to speak to why contrast made it to the recommendations and what contrast actually shows?
Yeah, I mean, there was a lot of discussion first. So this is a kind of statement that is not currently supported by prospective or very strong retrospective data. I think this is important to know. What I mean with this is that this is a recommendation that cannot be, I think, taken as a must in all cases. So the contrast medium can help us distinguishing the disease, scars, the surrounding tissue. So I think that an MRI with the contrast medium is probably the best, especially when you are planning the surgical resection or when there is a doubt of a relapse. While probably MRI without the contrast can also be accepted when there is a follow-up of a patient that has a really low risk to relapse. So I don't know if I answer your question and if Sebastian can add anything to this.
Yeah, I wanted to basically add that also from your feedback from the patient community, that there is such a broad spectrum of stuff that is being used for imaging, which is really confusing and of concern, because you had nothing in hand where you could say, well, this is what I believe I should get because this is recommended. So people would even do X-rays of a knee, for example, which is completely useless to take an image from a lesion like TGCT, because it's just invisible, or mostly invisible, unless you want to look at bone destruction, for example. So I think it's really important to help people to understand that MRI is standard of care. And if there is, as Silvia has said, a situation where surgery is considered, I think contrast media gives you the best version of where the delineation of the TGCT is.
And that's because contrast shows vasculature, right? It's because it goes in the blood and that shows something, versus the technique is different. It's just that the contrast goes in the blood.
Yes, so lesions that have a higher vasculature or vascular density and more blood flow to it would typically have a contrast media enrichment.
Thank you for
And then probably we can also ask that when a systemic therapy is considered and the patient is on therapy, the changes that we can observe in the contrast medium uptake can also add to changes in tumor sites. So this can be another reason to prefer MRI with contrast.
Well, that's great, because that gets into the last recommendation on the screen, is that the response to a drug, that MRI and an MRI with contrast, is really helpful to determine tumor size. So thank you for covering that one for me. And we can go to the next slide if you'd like. So when we talked briefly already about the pathology and molecular biology of the disease, if you want to hit it one more time, yeah, there's a recommendation within the consensus paper that suggests that the detection of the CSF1 genetic abnormality that all of us share only within the joint, that is not important or adds value to the clinical decision making. Dr. Bauer, do you want to speak to why that does not play a role?
Yeah, so it is from a research and science perspective, it has been a huge finding, and it's not that far back that it took quite a long time to know that there are these genomic changes. And this is why the disease also used to have a name that suggested that it might be just some kind of inflammation, because we were not sure that this is a neoplastic disease, which it is. And so it is really important to, as a researcher, to know that there is a translocation, and it's also great that this helped us to understand that there is a target for a medical treatment. But the expert pathologists clearly say we don't need to detect this to say this is a TGCT. And there's always a risk that people may rely on a genomic test that people may not even be masters of. So I think it has to be clear, it does not, none of the things that we do, none of the recommendations depend on the proof that there is a translocation. And this is why the pathologists, who of course love to do FISH and do those genomic testings, but they were also very conservative and thought this is really a diagnosis that is made under the microscope. You don't need the genomic, these genomic tests. And it's particularly important that actually a good pathology that has experience in making those diagnoses sees that.
So Dr. Stacchiotti, you're like the epitome, your institution, of what a good pathology review team can look like. Do you want to talk about the importance of having that type of expert specialist involved in the discrepancy between the disease and symptoms?
Yeah, sure. In general, in mesenchymal tumor, we always suggest to consider a pathologic review by an expert pathologist. These apply also to TGCT, and this is more important when the radiological features are not completely consistent with a TGCT. Indeed, there are other diseases that can enter differential diagnosis and can deserve to be treated in a different way. So as a group, we for this kind of tumor, we agree that not always a pathologic assessment before the surgical resection is required if the patient has a very clear imaging consistent with the TGCT diagnosis and the surgical resection is planned. But in all cases, when the pathologic diagnosis is not consistent with radiology, and I would add also when a systemic therapy is going to be considered, is correct, is better to suggest a pathologic confirmation by an expert pathologist.
Do you want to go to the next slide? And I'll just keep going with you because you're already on it about biopsies and the talk about whether TGCT really requires a biopsy or not. I think it's one more if you want to click. So that second recommendation is about whether a biopsy is recommended and how a biopsy should be done and whether they can be avoided if it's really confident that the disease is TGCT or not. And to Dr. Stacchiotti, you can keep going if you'd like. Or Dr. Bauer, if you have anything to add as well.
Yeah, I think this touches a topic that we believe there is some kind of a disconnect in the community of physicians who again thought this is a disease more like arthritis. And at least I can say that for Germany and Europe, and what our American colleagues told us as well, is there is not a strong tradition to centrally treat these tumors. And that is something that we hope all changes with these treatment recommendation, that people realize that they can really do harm if they don't work in interdisciplinary teams and are used to treating soft tissue tumors. And the topic of biopsy is something that if you have an expert team, that means that you might be able to make the diagnosis based on imaging. And if you are firm about making the indication that there is a need for surgery anyway, then you can basically make an informed professional expert decision to not take a biopsy, which is unusual for us as sarcoma experts. Typically, we would ask for biopsies, and that is often also the case for TGCT. But again, we felt in this treatment recommendation that this shouldn't be like carved in stone that you always have to make a biopsy. But as patients, I think if that decision is made, be sure that it's made by people who treat those tumors very regularly.
So also no panicking if you're getting a biopsy. That doesn't mean that you may have cancer. It doesn't mean that they're uncertain. It's just standard of care in some places as well, right? So going on to probably the most overarching theme of the entire paper, which is get referred to a multidisciplinary team that has a dedicated expert and team associated with this disease. Do you guys have any? So we did within the paper, one very interesting statistic was that those who were treated immediately upon diagnosis by an expert team had reduced recurrence rates around 42% with diffuse disease compared to those that were initially treated at community centers, which had around 92% recurrence rates. Do you guys want to speak to maybe some of the reasons for that and the importance of a specialized multidisciplinary team? And Dr. Stacchiotti, if you would like to start.
Yeah, I think that these data that you are presenting are really, really very important. We know that so far we do not have a systemic agent. We hope for the future, but at this time is not yet true, that can cure, can eradicate a TGCT when there is a relapse. So surgery is the main treatment modality and is the one that can cure a patient. Of course, surgery must be conducted in the way that is needed for a TGCT. There are several aspects that have to be considered. As we said before, for example, if we remove the lesion, breaking it into the cavity, the risk of a relapse is increased a lot. If we do not recognize the disease, and we simply think that it is a cystic lesion or is nothing, is a trauma, the approach changes completely, and the outcome for the patient can really change completely. So for this reason, both to recognize ahead of the surgical resection that disease is a TGCT and not a different tumor, maybe sometimes also a more aggressive disease that requires preoperative additional treatment, and to perform the correct surgical resection is really important to be seen at a center of expertise.
Dr. Bauer?
Yeah, not much to add.
Yeah,
I would just say that if you have like an arthritis or degenerative disease, you sometimes have this hyperplasia, this overgrowth of the capsule, and orthopedic surgeons can sometimes help patients by shaving off those kind of hyperplastic tissue. And again, that is not the way a sarcoma surgeon would resect a TGCT, and I think that is probably what one of the main reasons is. That doesn't mean that I think that these are like dumb physicians. I think it's a challenge. It's something that for us, it's always easy as medical oncologists to say that that should have been seen. But one thing is clear, the particularly orthopedic surgeons, the expert radiologists, they actually can recognize that it's a TGCT. So there's always a risk that it is undetected before, or that it is misdiagnosed. One can be thankful if the diagnosis is made right in the beginning.
And
yeah, so
also,
I was one of those patients, right? I was misdiagnosed, so it happens quite often.
Yeah, and in a way, moving to the next point, also active surveillance can be offered as a first approach. But again, this is a kind of decision that has to be taken within a multidisciplinary group that can discuss which could be the implication of a surgical resection or tumor growth in case the disease does not remain stable. For example, the surgery could change in case of an increase. So all these aspects are all very delicate, even though we are not talking of a malignant tumor.
So that perfectly, you're the perfect segue for all parts of this. So I wanted to also ask, we got a question someone submitted about MRIs being used for active surveillance. So if you are someone who is just watching the disease, waiting, maybe you're not entirely symptomatic or you just want to see the growth, how often would your institutions do MRIs for that monitoring?
So I think that, again, we need to say that we do not have prospective data. This is very important because it's not very clear how the outcome could change if the identification of a disease progression is delayed of some months. This said, I think that as we commented at the end of the position paper, the MRI could be considered every 6 months if the patient is asymptomatic and the lesion is not located in a dangerous position. This dangerous place is uncommon, but can be seen sometimes, the spine, for example, and in those cases, if tumor growth can worsen the prognosis of a patient in a clinically meaningful way, could be safer to assess the tumor more often. Otherwise, I think that twice per year is enough, but I don't know if Sebastian agrees, if they have a different policy.
No, I totally agree.
So as someone with chronic back pain, like everyone else, and you may have it in a different joint, right? You don't panic when you have back pain now. This disease doesn't spread. Dr. Bauer, do you want to comment on that the disease kind of stays within a mono joint region?
Yeah, I can just support that. But what you're saying, that it's a burden for every patient who has some kind of tumor or a cancer. And I mean, TGCT is not a classic form of it's not a disease that spreads. These ultra rare situations of patients that are even so rare that we felt we should kind of keep this out of this recommendations, mostly because it totally distracts people that this is a localized disease, and this is very important for everyone to take home for today. This is not a life-threatening disease for most patients, with the few exceptions that Silvia said, that there are some very, very rare, unlikely anatomical sites that can be affected, that are dangerous, and that may require more close monitoring. But yes, it's true, it's a localized, non-metastasizing disease. And again, it's a clinical decision if you have additional symptoms, whether it's in connection with that, and you should seek out your doctor if you have that. And I would not hesitate. I mean, if you have symptoms, go and ask and discuss whether it makes sense to do an additional diagnosis. You don't have to make that decision on your own, and your doctor should be perceptive if you're concerned about symptoms.
That's the multidisciplinary team, right?
And on the other side, I think that quality of life can, measure in a different way according to the age of a patient, the work, the job, the activity, the kind of entertainment. So it can be that I'm used to make this example, a small lesion on a finger of my hand has no clinical relevance for someone who is maybe a teacher, but can be a very serious problem for a piano player. So also the right timing for considering a treatment can be different for the same kind of lesion in different patients. And surveillance or an active treatment, the kind of monitoring can also be tailored according to the different needs of a patient.
Perfect. So we can go forward a little bit as well on the slides. So we kind of briefly discussed the decision on whether to do active treatment versus surveillance as a very intricate patient and provider specific conversation. So we can move forward a little bit as well, being cognizant of time. I want to make sure we get through everything. So you can show all of them if you'd like. So I think there's one more. So when we discussed surgery itself, the removal of it should be done only, or in the case that you can remove all of it without significant complications. You guys don't think that debulking or removing part of it is improves quality of life, do you, or do you not, or do you have thoughts on that? And I'll start with Dr. Stacchiotti.
So as a general rule, I think that debulking is not the best surgical option for a patient. Of course, there can be exception. I think that we need to know that debulking surgery is not curing any patient. The disease is going to not really relapse, to remain there, and is never justified when the morbidity, which means the side effects, the consequences of the surgical resection are responsible for a worsening of the quality of life. There could be exception in which debulking surgery in a patient that cannot undergo a complete surgical resection in a relapsed patient can be considered in particular cases. So on a general rule, no, then there can be exception.
Always nuances, right? Dr. Bauer, your turn.
Yeah, I agree. I can tell from my own practice that I so often hear stories from patients who say that repetitive surgery, for example, has had detrimental effect, where they feel that the consequence of repetitive surgery had more negative impact than the disease had before the surgery. So that the decision that was made at that date was not balanced. And that is something that is in these recommendations that every local treatment should think about or try to predict what the consequences are. I totally agree. Debulking, particularly in a first, as a first treatment, is something that should not be aimed for, particularly if there is a chance that you have alternative treatment options.
Thank you for both of your very thoughtful options. And then I want to quickly just glance over radiation therapy. And within the paper, this was discussed kind of widely. And within the patient paper, oh, you can go back once. It's at the last two on that screen. And within the patient paper, we made a stronger stance on radiation and kind of made it more of a recommendation against. Whereas in the paper, it was a very big discussion on whether it should be used and when it shouldn't be. So do you guys want to just discuss what it settled at and why there were hesitancies to make a really strong statement against it, both external beam and locally acting? And I'll start with Dr. Bauer.
Yeah, thanks to Sydney Stern, actually, there is a firm statement on this. So again, there is most big sarcoma centers believe that TGCT is not a disease that should be treated with radiation because there's really no strong evidence that it helps to reduce the relapse rate. And we also have very little evidence that in irradiating tumors that are visible, that you see a lot of shrinkage, something that we see with a lot of malignant tumors. So based on this, we, like our center, many other centers, do not irradiate at all. And there was discussion for a more liberal recommendation from one or two experts that say, well, this is an option. But again, you reminded everyone that this kind of ambivalence towards radiation therapy is not helpful to the patient community. And I think it was very helpful that we discouraged the use of radiation therapy. And I think that there are very, very unusual situations where one could think about it.
Dr. Stacchiotti?
I cannot agree more. I'm very happy that we ended by discouraging radiation therapy. I confirm that also at our institution, radiation therapy is never provided as an advisable option for TGCT. Even the more today that we have systemic compounds and also other local regional treatment that can be considered.
Thank you. Thank you for touching on that. I think that's talked about a lot. And so going to the next, which is that we have medical oncologists. So what a great conversation about the recommendations there. And that speaking solely about symptomatic disease. So patients who are experiencing suffering of the disease, that they would consider a medication option. When would you give those patients medications? Under what circumstance? Do they have to have a certain amount of surgeries, or can they come in at time of diagnosis? What are those considerations? Dr. Stacchiotti.
I think that here we need to acknowledge that systemic agents potentially active for TGCT are not available at the same level all around the world. So each of us has to adapt to what is prescribable at local level. So in our site in Italy, in general, we stick with these recommendations. So we offer a systemic therapy to patients with symptoms, and usually we also consider a kind of preoperative systemic therapy when there is a chance to improve the surgical resection and the chance of a cure by shrinking the tumor before removing it. But this is a kind of exceptional situation, exceptional condition. On a general rule, we prescribe tyrosine kinase inhibitor like imatinib when there are no clinical trial available, as pexidartinib is not, unfortunately, is not available in Europe, or otherwise, our first choice are experimental treatment if they are available. I don't know, Sebastian, if you have a different.
I think medical treatment, and if I would practice in the US, pexidartinib is the only approved treatment. So that would be, of course, the treatment of choice in the US. We would offer medical treatment to patients where the surgeon says, I don't think I can get this out without seriously hurting the knee. So if there's symptomatic disease and curative surgery appears to be associated with high morbidity, so with long-term side effects, that would be the trigger for offering medical treatment.
So a lot of people are asking specifically about Tralia, which I know is not approved, but both of you were part of the trial and you're part of pretty much every trial that's been done in TGCT. So how do you weigh the toxicity involved in the duration? I know many of us talk about like, how long are you going to be on these treatments? How do you guys weigh that?
So with regard to the for how long the treatment has to be administered, I think that we do not have yet a definitive answer, even though we hope that for the Connective Tissue Oncology Society in November, we will have presented the data of the discontinuation study on pexidartinib. There are not going to be many cases, but at least some more clear answer could be available from there. Missing this information for now, we usually continue the treatment if we are within a study according to the study protocol, if we are outside a study according to the patient symptoms and desires and wishes. When usually when we have the complete resolution of symptoms, we start considering to stop the treatment and maybe to re-challenge in case of further progression.
The one question we get a lot is about pregnancy and women who want to start families. This disease predominantly affects younger people. So do you have, I know within the family, right, we're talking about a lot of drugs here, but do you consider patients freezing their eggs, and how do you go about the discussion on whether there's implications for fertility?
So I start. Okay.
Yeah.
With regard to imatinib, I think that from other tumors in which the drug is used, we know that this is not needed. So we do not like to administer imatinib during a pregnancy, but we do not, and especially in a benign tumor like TGCT. But if a patient is young and she's planning to have children for the future, and we consider imatinib for a while, we never suggest to go for preservation of the ovary function. While I don't think we have for now enough information about pexidartinib, even probably, I don't know. What do you think about that, Sebastian?
It is a tough decision because, I mean, and I've had patients with that particular situation, and again, we strongly advise against getting pregnant while on these drugs, and this should really be made sure that one doesn't get pregnant while on these drugs, because it could harm the unborn child. So, and it's really not safe. I think it's a lifetime decision with a disease that is not a life threat, that you may make the decision to pause the drug for a time and accept that during that time you may have worsening of symptoms. And this is what some of my female patients have decided to do.
But they're still able to have children.
Yeah, I don't think that we have a lot of evidence that any of these drugs is causing like a long-term impairment, something that we typically see with some of these intensive chemotherapy regimens. That is something where we have quite a large body of data that for example, after the typical breast cancer chemotherapy, there's a risk of 50% that you lose your fertility or are not able to get a child later. But for these tyrosine kinase inhibitors, I'm not aware that there's data of actually infertility in women.
Perfect. That's a big hot topic. And a lot of people also wonder if the hormones make the disease worse. And I just want to make sure that you guys can dispel any thoughts that pregnancy hormones or any sort of sex-based hormones would affect the disease. That one's an easy one, at least. Do you want to go a little further? So part of the question and answer, and the last on the systemic, which will be a great transition for our last few minutes, is have you guys considered, I know all of these drugs are in trial, so it's very difficult to use it outside of trial, but using imatinib or pexidartinib or any of the drugs, have you considered the potential value of using those as a precursor to surgery or after surgery to reduce recurrence? How do you feel about maybe that modality, knowing that there's no current data being used? Dr. Bauer, you can go first.
Yeah, so I would say that again, we use it very similar to what Silvia has described a little earlier. So if there is like very advanced disease, I think if we test that a patient may respond, I think we would use it and tell the patient that we want to find out whether it could improve surgery. It's something that we discuss together with the surgical team. So if there is a considerable risk of morbidity, so side effects from surgery, then we would do it, and we would then wait for the outcome of the surgery. And we personally would not add adjuvant or post-operative imatinib if the surgeon says, and the pathologist then confirms, well, the disease is completely resected. We don't have evidence that a curative resection is improved by adding imatinib or any other TKI. I think it's not supported by any data. It is a different situation if, for example, like a decision is made that, for example, a relapsed disease, which we believe is not cured by surgery, and that a patient has received debulking surgery for whatever reason, then I would very much consider to put patients on a treatment to avoid relapse. But that is a kind of a different situation, because it's a situation where tumor regrowth is basically inevitable, and you want to keep the patient in a situation where the TGCT does not cause problems by blocking a joint. I don't know, Silvia, if that is.
No, I fully agree with you. And this is, as I said, a benign tumor, so we really do not have any data to support a kind of a precautional use of tyrosine kinase inhibitor. In case of any toxicity, we could not justify the reason for this kind of side effect, while to help the surgical resection, especially when the surgical resection is really potentially curative, I think that even though outside the label, this could be considered, should be.
Well, thank you both. If you have enough time for one more question, I'll ask another question as well. So the last question being that, so we put all this work into it. You guys have been instrumental in making the first ever consensus paper for our disease. How do patients know whether their provider is up to date on this information? Dr. Stacchiotti, do you have any tips and tricks on seeing or deciding if your provider knows this information, and maybe how to weigh that?
I think that, you know, a patient first can always provide, at least with the live version of the document, the general practitioner and the local potential treating physician. On the other side, I think that this is a kind of a question that has to be answered at the country level. as in each country, there could be a list of centers with a major experience in this disease. These kind of institution, especially now that they can have your help, I think can be identified.
Dr. Bauer?
Yeah, I think I think in this context, there are a few things to consider. First, there are very passionate people who help other patients like you. TGCT support is like a place where you can get in touch with and ask, well, do you know an expert? That doesn't mean that your doctor is not good in treating this, but you can get a positive recommendation of people who are involved in the community. So that is one thing. I always think that as a patient, you don't need to stop using your brain. So I think you can always read these things. I think the document is not like it's not a picture book for children. It is a challenging piece of information, but I think it's always good trying to understand where do I fit into this. And I'm always happy when patients hand me over a document or something they found. I think a normal reaction should be that you should ask your physician, well, do you know about this consensus? Is that something that you use for making the decision? Because I feel that this is a very helpful document. I think I would be proactive, and we as physicians, I think most of my colleagues are thankful when they get a good suggestion by a patient or by a colleague. Personally, I think you should pay physicians that are perceptive to that kind of questions. Those are the physicians that can be trusted, I think. At least that's a good indicator that someone is willing to accept that question.
Wise words from both very elite experts in the field. So thank you very much for your time and your efforts in this. This specific video will be on our YouTube, and it will be translated into all of the various languages you could imagine. So it's very easily accessible to everybody involved. And I will like to point out that some of these questions that are still kind of uncertain at this moment, we do have a prospective patient registry. We have over 500 patients who have answered it within the year. And that's a way that we can hopefully collectively garner some of this information in a proactive way. So I just want to put a plug out there for our registry as well. And thank you both for your time. And we did have additional questions, a few, and so maybe we'll have additional webinars to follow. So thanks everyone for your time.
Thanks very much, Sydney, for organizing, and thanks everyone for spending this time with us. We are always available when needed.
Yeah, thank you also for your help, and thanks to Sarah. Thanks also to Spang, who are instrumental also in Europe, and like the German Sarcoma Foundation, which is something, it's instrumental to empower patients to seek out information for themselves and connect patients. So that is tremendously helpful. So thank you for your work.
Thank you everyone for attending, and have a good evening, morning, afternoon.
Thank you. Bye.